Hello students, welcome to this session in abdomen on anterior abdominal wall. Okay, so in this session we are going to see a lot about anterior abdominal wall. What are the layers of the anterior abdominal wall? What are the muscles present, their attachments, their modifications, also about inguinal canal and inguinal hernia, and lastly about the rectus sheath. Fine, I'll write this case scenario for you. 70-year-old Mrs. Padmama presented to surgery OPD with complaints of dragging pain over her right groin. She was a known case of pulmonary tuberculosis on medication. On physical examination, a small globular swelling was noted in the right groin above the pubic tubercle. The swelling expanded on coughing and was reducible. She was diagnosed with right-sided inguinal hernia and a surgery was planned. Okay, so Mrs. Padmama, what was her problem? A swelling over the groin. So yes, and we have concluded it is going to be like inguinal hernia because of the dull aching pain and then a globular swelling over the right groin, and it was expansile, right, on coughing. It was also reducible. So where is this hernia? In the inguinal region, and in detail in this session we'll be talking about inguinal canal. Okay, so shall we start? Let us identify the layers of the anterior abdominal wall. To start with, this is the skin. Beneath the skin, we have the superficial fascia, isn't it? And beneath the superficial fascia, we get to see three flat muscles in the anterior abdominal wall. From outer to inner, it is going to be external oblique muscle, inner to it, internal oblique muscle, and inner to it, transversus abdominis muscle. Inner to the transversus abdominis muscle, we have a fascia, a thin fascia, which we are going to call it as fascia transversalis, which lines the inner aspect of the transversus abdominalis muscle. Okay, and inner to the fascia transversalis, this is actually the parietal peritoneum, but this parietal peritoneum is separated from the fascia transversalis by the loose extraperitoneal connective tissue. Okay, so totally how many layers? 1, 2, 3, 4, 5, 6, 7 and 8. What about the deep fascia? Is it present or absent in the anterior abdominal wall? The deep fascia is absent in the anterior abdominal wall. The anterior abdominal wall is firm and elastic. Okay, this deep fascia is absent in the anterior abdominal wall because inside the abdominal cavity we are have the organs which can expand, right? The stomach, the intestines, the uterus, the urinary bladder, all that. Okay, so if we are going to have a deep fascia, it will prevent the expansion of the abdominal cavity, the abdominal wall, right? And yes, this part, so this is the umbilicus, here the pubic symphysis. Midway between the umbilicus and pubic symphysis, this superficial fascia, okay, this lower part, this point, it is split into two layers. Outer fatty layer, which is called campus fascia, and inner membranous layer that is called the scarpa's fascia. A point midway between the umbilicus and the pubic symphysis. This fascia scarpa is the membranous layer which will be replacing the deep fascia. Okay, so here can you identify? This is going to be our external oblique muscle, and just outer to it, this is the fascia scarpa, and outer to this, the fatty layer that you see here is the fascia camper. Here, this is the penis, the scrotum, the perineum. Here, this is the pubis bone, the urinary bladder. Below the urinary bladder, this is the prostate. surrounding the neck of the urinary bladder. This is the urogenital diaphragm. Okay. Can you see the urethra passing through the, the neck of the urinary bladder, through the prostate, urogenital diaphragm, and the penile urethra entering the, penis. Okay. Now coming to the fascia scarpa. So the fascia scarpa that we see here, if we further trace it down, it is going to, become continuous with the fascia of the penis. Behind that, it becomes continuous with the dartos muscle of the scrotum that lies immediately beneath the skin of the scrotum. And then into the perineum, the deep fascia of the perineum is called Colles fascia. It becomes continuous with the Colles fascia, and this Colles fascia, it fuses with the posterior aspect of the urogenital diaphragm. Okay, why is this important? Because if there is going to be a rupture of the penile urethra, what will happen? The urine from the penile urethra, it is going to extravasate into this part of the perineum, which is called the superficial perineal pouch. And then around the scrotum, it collects around the scrotum, around the penis, and it also extends into the lower part of the anterior abdominal wall. The space beneath the fascia scarpa in front of the external oblique aponeurosis. But it doesn't extend to the thigh because this fascia scarpa, it fuses with the deep fascia of the thigh, the fascia lata, along the Holden's line, isn't it? So this is very, very important while we talk about the layers of the anterior abdominal wall. Right. So apart from the three flat abdominal muscles, what are they? The external oblique, internal oblique, and the transverse abdominis. On either side of the midline, we get to see the rectus abdominis muscle, which lies enclosed within the rectus sheath. Okay. And the nerve supply, it comes from the ventral rami of T7 to T12. T7 to T11 are called intercostal nerves because they been in the intercostal space between the ribs. The T12, it lies below the 12th rib, right? So we are going to call it as the subcostal nerve. Fine. So the ventral rami of T7 to T12, okay, so they run in the neurovascular plane that is between the internal oblique and the transverse abdominis muscle. On reaching the rectus sheath, these nerves, right, they pierce the internal oblique, they'll enter the rectus sheath, they supply the rectus abdominis muscle also. And the skin, overlying skin, the dermatomes there. So you can make out the umbilicus here. The nerve supply in the skin, in the region, the dermatome of the umbilicus is by T10 spinal nerve. Below that will be T11, T12, and along the inguinal ligament groin, it is by L1. Above T10, it's going to be T9, T8, T7, T6, and so on. Okay. So the dermatomal innervation, especially the umbilicus, is important. Now let us see about these flat abdominal wall muscles. To start with, the external oblique, you can easily identify in the cadaver or in an image-based question. So this is the superficial one, and this external oblique, it comes from the ribs, the lower 8 ribs. The fibers of the external oblique, they are directed downwards, forwards, and medially, like the hands in the pocket. They come down for insertion into the iliac crest, the ventral segment of the iliac crest, into its outer lip. Okay, and you can see it forms a upper neurosis This external oblique, this upper neurosis, the lower border of the upper neurosis, it is going to be like thickened, forms the inguinal ligament. The lower border, the thickened lower border of the external oblique upper neurosis that extends from the anterosuperior iliac spine medially to the pubic tubercle. Okay. So this upper neurosis, the lower part we saw, it's going to form the inguinal ligament. The rest of it, what happens? It goes anterior to the rectus abdominis muscle. It will form the anterior wall of the rectus sheath. And then in the midline, in the midline, it will decussate with similar fibers of the opposite side to form the linea alba. The inguinal ligament we saw, it extends from the anterosuperior iliac spine to the pubic tubercle. There are 3 extensions from its insertion into the pubic tubercle. Few fibers, they turn backwards and medially and they insert into the medial part of pecten pubis. These fibers are called, the lacunar ligament of Gimbernat. The base of the lacunar ligament, it forms the medial boundary for femoral ring. Fine. Some of the fibers will continue from the base of the lacunar ligament to reach the iliopubic eminence, right? These fibers are called pectineal ligament of Cooper. Some of the fibers are reflected upwards and medially. They pass in front of the conjoint tendon to insert into the linea alba. These fibers are called reflected part of the inguinal ligament. They are related to the posterior wall of the inguinal canal in its medialmost part. Now, can any one of you tell me what is the other name for this inguinal ligament? The Foupart's ligament. Okay. The external oblique upper neurosis, as we saw, it forms the anterior wall of the rectus sheath and then it goes ahead to form the linea alba in the midline, isn't it? And here, just above and lateral to the pubic tubercle, it presents a triangular opening which we'll call it as the superficial inguinal ring. Through the superficial inguinal ring, you can see something exiting out. What is that? The spermatic cord. The spermatic cord is nothing but it has the vas deferens, the blood vessels, the nerves, the lymphatics to the testes. Okay. So this spermatic cord, it is going to traverse the inguinal canal. It exits out through the superficial inguinal ring. Now, the superficial inguinal ring is a defect in the upper neurosis of the external oblique just above and lateral to the pubic tubercle. From the margins of the superficial inguinal ring, we'll get the external spermatic fascia. Okay. Again, we saw that, the upper neurosis is going to contribute to the rectus sheath. It forms the inguinal ligament. We should also know what is the relation of this external oblique upper neurosis to the inguinal canal. Where is the inguinal canal? So this is our inguinal ligament, isn't it? From the anterosuperior iliac spine to the pubic tubercle, the inguinal ligament, the inguinal canal, it lies just parallel to the medial half of the inguinal ligament. Okay. And this external oblique upper neurosis, it will form the anterior wall of inguinal canal. The inguinal ligament and lacunar ligament that we saw now, they will contribute to the floor of the inguinal canal. And the reflected part of the inguinal ligament, yes, an extension of the inguinal ligament, it will contribute to the posterior wall of the inguinal canal. So while in upper limb, while doing muscles of back, we saw that there are two important interesting triangles. One is the triangle of auscultation and the other is the lumbar triangle of Petit, isn't it? This lumbar triangle of Petit, yes, do you remember the boundaries of it? In front, what we see here is the external oblique aponeurosis. Okay, this one is the latissimus dorsi. The base is formed by the iliac crest, and in the floor, the muscle that you see here is the internal oblique. Okay, so this is a better view, lateral aspect. This is a lumbar triangle of Petit. Okay, so anteriorly what we see here is the posterior border of the external oblique aponeurosis. And posteriorly what we see here is the anterior border of latissimus dorsi. Below it is the iliac crest. And in the floor, it is the fibers of the internal oblique muscle. So we have to remember that this external oblique muscle contributes to the lumbar triangle of Petit, which is a weak area in the abdominal wall through which the intestinal contents can herniate out, producing the lumbar hernia or Petit's hernia. To summarize, yes, we'll recollect the external oblique aponeurosis in relation to rectus sheath, anterior wall of the rectus sheath, its medial margin, the linea alba, right? Inguinal ligament from the anterosuperior iliac spine to the pubic tubercle and its three extensions, the lacunar ligament, the pectineal ligament and the reflected part of the inguinal ligament. And then in relation to inguinal canal, it contributed to the anterior wall, to the floor and the posterior wall. Yes, and the defect in the external oblique aponeurosis superficial inguinal ring, which forms the outlet of the inguinal canal. From the margins of it, we get the external spermatic fascia, right? And of course, one of the boundary for the lumbar triangle of Petit. So as you see here, it is a very important topic. Lot of MCQs and image-based questions can be related to it. Moving on to the next muscle, the internal oblique, which lies inner to the external oblique. This internal oblique muscle, it arises from below and goes upwards, okay, these fibers. The fibers which originate from the inguinal ligament, they come from the upper surface of the lateral 2/3 of the inguinal ligament. So please remember these fibers, okay? Yeah, we'll be talking about it separately. It will also come from the ventral segment of iliac crest, its intermediate area. And also from the fusion of the anterior and the middle layers of the thoracolumbar fascia. These inguinal fibers coming from the inguinal ligament, it is very important. So this is a spermatic cord, right? Okay, so we can see these inguinal fibers arching over it. Okay, the arching fibers, they form the roof of the inguinal canal. And then it goes backwards, medially downwards to insert into the pubic tubercle. So this part which goes backwards, downwards, medially, it will fuse with similar fibers of the transverse abdominis to form the conjoint tendon. The conjoint tendon of Fox inguinalis is the inguinal fibers after forming the roof, which turns downwards and backwards medially to insert into the pubic crest and tubercle. It is contributed also from the transverse abdominalis. The major contribution is from the aponeurosis of transverse abdominalis. 2/3 is from transverse abdominalis and 1/3 is from the internal oblique, right? And yes, as we see here, the aponeurosis. We have seen about the inguinal fibers contributing to the the roof, yes, and the posterior wall of the inguinal canal through the conjoint tendon. Another interesting feature of this internal oblique muscle is that the fibers of this muscle, it will continue around the spermatic cord as fasciculi. And these muscle fibers that surround the spermatic cord is called the cremaster muscle, which is innervated by genital branch of genitofemoral nerve. When this muscle contracts, what happens is that you can see the testes here within the scrotum. It will pull the testes and occlude the superficial inguinal ring, which is one of the important defense mechanism to prevent herniation in the region of the inguinal canal. Okay. And something very special about the upper neurosis of internal oblique. Yes, what you see here, this is the upper neurosis. We saw the inguinal fibers arching over, forming the roof, and then the conjoint tendon. What about the other fibers? So these fibers, they go up, they form an upper neurosis. Some of them insert into the lower 3 or 4 ribs. This upper neurosis, okay, midway, so this is the costal margin. So from the costal margin to a point midway between the umbilicus and the pubic symphysis, in this area, this upper neurosis is going to split into a anterior and posterior lamella. The anterior lamella will pass in front of the rectus abdominis, forming its anterior wall. The posterior lamella will go behind the rectus abdominis to form the posterior wall of the rectus sheath in this mid-segment, but lower down, okay, below this area, in the lower part, what happens is that the entire upper neurosis, it goes in front of the rectus abdominis to form the anterior wall of rectus sheath. Fine. So, internal oblique muscle, to summarize, please remember, in relation to inguinal canal, it formed the roof and the conjoint tendon contributed to the posterior wall. In relation to rectus sheath, what happened? In the area midway between the costal margin and a point midway between the umbilicus and the pubic symphysis, it split into 2 lamella, contributing to both anterior wall and the posterior wall. And in the lower part, only the anterior wall. And yes, of course, the cremaster muscle innervated by the genital branch of genitofemoral nerve. And if you remember, yes, the lumbar triangle of Petit, we saw the fleshy fibers of internal oblique in the floor. Moving on to the transversus abdominis muscle. So, innermost is the transverse abdominis muscle, this one that you see here. So, this muscle, it again arises from the upper surface of the inguinal ligament, its lateral 1/3, and from the inner lip of the iliac crest in its ventral segment, and also from the thoracolumbar fascia. These fibers, yes, the inguinal fibers, as we saw, similar to the internal oblique, they will form the roof and the conjoint tendon. The conjoint tendon, its other name is Fox inguinalis, though it is contributed by both transverse abdominis upper neurosis and the internal oblique upper neurosis. Please remember, 2/3 of the contribution is from transverse abdominalis and 1/3 is from the internal oblique. Fine? Yeah. And then we have seen that the neurovascular plane, it lies between the transverse abdominis muscle and yes, the internal oblique muscle. Fine. The upper neurosis of this transverse abdominis muscle, yes, it will lie posterior to the rectus abdominis. It will contribute to the posterior wall of the rectus sheath. Below the costal margin, a point midway between the umbilicus and the pubic symphysis. Okay. And in the lowermost part, the upper neurosis of external oblique, internal oblique, and the transverse abdominis, all the three in the lowermost part, below that point midway between the umbilicus and pubic symphysis, will contribute to the anterior wall. Fine. Now, inner to the fascia transversalis, we'll get to see this thin, filmy, transparent layer, fascia transversalis. Okay, so inner to the fascia transversalis will be the extra peritoneal connective tissue, and then this is the parietal peritoneum. So, the fascia transversalis, its contribution is also very, very important. We see the inguinal ligament here, right, from the anterosuperior iliac spine to the pubic tubercle. Just behind the inguinal ligament, the fascia transversalis, it thickens, okay, condenses to form the iliopubic tract, again extending from the anterosuperior iliac spine to the pubis. It is also called as the Thomson's tract. So this part of the fascia transversalis, it will contribute to the deficiency of the posterior wall of the rectus sheath. Yes, below the arcuate line. And very interesting part is that the presence of one deficiency, a oval area in the fascia transversalis, it's called the deep inguinal ring. And through this opening, the spermatic cord in the male or the round ligament in the uterus, it enters the inguinal canal. So where is this actually situated? 1.25 centimeter above the mid-inguinal point. Okay, it lies just lateral to the inferior epigastric vessels. From the margins of this deep inguinal ring, we get the internal spermatic fascia. So the external spermatic fascia is an extension from the superficial inguinal ring, and inner to that we have the cremaster muscle that comes as an extension from the internal oblique muscle, and then inner to that we have the internal spermatic fascia, which is nothing but coming from the extension from the margins of the deep inguinal ring. That's the fascia transversalis. Right. And while doing lower limb femoral triangle, yes, we saw that the femoral vein and artery, they lie within the femoral sheath. And do you remember the anterior wall of the femoral sheath was contributed by this fascia transversalis. The posterior wall of the femoral sheath is contributed by the fascia iliaca. Fine. Now let us see the parietal peritoneum, some interesting features in it because this can be a spotter in your practical examination. So this, we are looking into the anterior abdominal wall from an inner view. What you see here, this muscular organ, yes, can you tell me what it is? It is the urinary bladder. Okay. Below that, you can see the prostate here. Fine. And this is the region of the umbilicus. Can you make out 3 peritoneal folds there? This one in the midline, and this one just lateral to it, and this one even more lateral. So from the midline, if we begin, this is going to be the median. We'll call it as median umbilical fold. And just next to it, this is the medial umbilical fold, and just lateral to it, this is the lateral umbilical fold. Okay, so these folds are covering something that lies within it in the extraperitoneal tissue. So the median umbilical fold, what lies underneath it is the median umbilical ligament, which extends from the apex of the bladder to the umbilicus. It's nothing but the remnant of urachus or the allantoid diverticulum. We'll be learning it in detail in our embryology session. Okay, and the medial umbilical fold, what lies underneath it is the obliterated umbilical artery. The lateral umbilical fold, you can see something, a vessel lying underneath it. It's nothing but the inferior epigastric vessels. Okay, so this is important. And this area between the fold, we are going to call them as fossa. So between the median and medial umbilical fold, we'll call it as the supravesical fossa. Just lateral to it, between the medial and lateral, this will be the medial inguinal fossa. And lateral to the lateral umbilical fold, this will be the lateral inguinal fossa. Okay. Moving on to a very important landmark in the anterior abdominal wall, which is on the inner aspect of the anterior abdominal wall, Hesselbach's triangle. It's a very high yield topic, right? So this Hesselbach triangle, it is a peritoneal triangle. And we can see it over the, as I told you, inner aspect of the anterior abdominal wall, over the posterior wall of inguinal canal. The boundaries of this Hesselbach's triangle is bounded medially by the lateral border of rectus abdominis muscle. This is the rectus abdominis muscle. The lateral border of rectus abdominis muscle contributes to the medial boundary. And laterally, by this lateral umbilical fold, and what does it contain, this lateral umbilical fold? The vessel that you see there, just now we saw, right? The inferior epigastric vessels. Can you tell me this inferior epigastric artery, what is it a branch of? It's coming from the external iliac artery that you see here. The external iliac artery, it gives rise to two branches. One is the inferior epigastric artery in the lateral umbilical fold, and just lateral to it, remember we saw the deep inguinal ring, and the second branch is the deep circumflex iliac artery. The base of the Hesselbach's triangle is formed by the inguinal ligament. So this is the area of the Hesselbach's triangle. Medially by lateral border of rectus abdominis, laterally by the inferior epigastric vessels, and below by the inguinal ligament. Fine. What is the importance of this triangle is that it is a weak area in the abdominal wall, anterior abdominal wall, in the region of the posterior wall of the inguinal canal, through which the intestinal contents can herniate out, causing a direct inguinal hernia. Fine. Another picture to show you this Hesselbach's triangle. Okay, so this one that you see here is the rectus. I'll draw this side. What is shown in dotted line, this is the Hesselbach's triangle. Okay, so this is the rectus muscle. We are viewing it from the inner aspect, right? And this again is the lateral border of the rectus abdominis. Can you appreciate the inferior epigastric vessels here forming the lateral boundary, and below by the inguinal ligament? Please remember, where is our deep inguinal ring? It is going to be located just lateral to this inferior epigastric vessels, and the hernia that comes out through the Hesselbach's triangle is going to be the direct inguinal hernia. And yes, the inferior epigastric vessels lie just lateral to this hernial sac, or the hernial sac, it lies medial to the inferior epigastric vessels. Now, moving on to a very important topic, frequently asked essay question, lot of MCQs around it, and clinically very important, inguinal canal. So far we have revised what are the layers in the anterior abdominal wall, and then we went through each layer, right, including the dermatome over the skin, and then about the fascia scarpa, fascia camper, And then we saw about external oblique muscle, its modification, internal oblique muscle, its modification, transverse abdominis muscle, fascia transversalis, and then the parietal peritoneal folds, Hesselbach's triangle. Now, the second part of this session, inguinal canal. So this inguinal canal is oblique, right? It is oblique, as you see here. It is oblique and it is situated within the layers of the anterior abdominal wall between the three flat muscles that we saw. Okay, so and their upper neurosis. Hence, it is a musculo-upper neurotic tunnel. It measures 4 centimeters in length. We know this is the inguinal ligament that extends from the anterosuperior iliac spine to the pubic tubercle here, right? This inguinal canal is situated just above and parallel to the medial half of the inguinal ligament, right? So, in the cadaver, just feel for the anterosuperior iliac spine, the pubic tubercle, you can see the inguinal ligament. Now, where will you look for the inguinal canal? Go to the medial end, right? Just above the medial half of the inguinal ligament, we'll get to appreciate the presence of inguinal canal, which is well developed in the male because of the passage of spermatic cord. Okay, yes. This inguinal canal, it extends from the deep inguinal ring to the superficial inguinal ring. Yes, now you can tell me the deep inguinal ring is an opening in the fascia transversalis. And the superficial inguinal ring, it is an opening in the external oblique upper neurosis. Okay, so this will help you understand that the superficial inguinal ring and the deep inguinal ring, they are not in the same plane. Fascia transversalis is more inner and the external oblique upper neurosis is more superficial. So it is oblique and across, right? Yes. The direction of the inguinal canal, it is oblique. It is directed downwards, forwards, and medially. Fine? And as I told you, it is well defined in the male because of the presence of spermatic cord. What does the spermatic cord contain? It has the vas deferens. It has the vessels that supply the testes. Okay, it has the testicular artery and then, artery to vas deferens and the pamptiform plexus of veins, the nerves, the lymphatics. Okay, so it is well defined in case of a male, the inguinal canal. Whereas in the female, it is going to be the round ligament, which is not like that very thick as the spermatic cord. So in female, the inguinal canal is very narrow. So the chance of inguinal hernia is also less. In children, the anterior abdominal wall muscles, they are not that well differentiated. So the inguinal canal is not oblique, but more straightforwards. Fine? So as I told you, the contents in the male will include the spermatic cord. In the female, it will be the round ligament. In both male and female, we have the ilioinguinal nerve traversing the inguinal canal. But what is interesting is that we have to call it as partial content of inguinal canal. Because we know the inguinal canal, it extends from the deep inguinal ring to the superficial inguinal ring. The spermatic cord, the round ligament of the uterus, all will enter through the deep inguinal ring. They traverse the inguinal canal and exit out through the superficial inguinal ring. But this ilioinguinal nerve, it will not enter the inguinal canal through the deep inguinal ring. Instead, it will pierce the roof. It will traverse halfway of the inguinal canal and exit through the superficial inguinal ring. Okay, hence we call it as partial content of inguinal canal. This inguinal canal, yes, let us look into its walls. Okay, so it is going to present floor, anterior wall, the posterior wall, the roof. Okay, and it has an inlet that's going to be the deep inguinal ring and an outlet, the superficial inguinal ring. Let us look into each boundary with details. So the anterior wall of the inguinal canal. The anterior wall of the inguinal canal, yes, you can tell me, it is going to be contributed by the skin, superficial fascia, and beneath that the external oblique upper neurosis. This anterior wall is strengthened on the lateral aspect by the origin of fleshy fibers of internal oblique muscle. Remember, the external oblique originates from the lower 8 ribs and comes down for insertion, whereas the internal oblique and the transversus abdominis muscle, they originate from below and then they go upright. Yes. And all of them, the upper neurosis, it merges in the midline to form the linea alba. Coming to the posterior wall. The posterior wall of the inguinal canal in its whole extent, it is going to be formed by fascia transversalis. This fascia transversalis, it lies inner to the transverse abdominis muscle. And remember, we saw that the opening in the fascia transversalis 1.25 centimeter above the midinguinal point, the deep inguinal ring, and from the margins, the internal spermatic fascia come, right? Okay, so this fascia transversalis, it forms the posterior wall of the inguinal canal, which is further strengthened in the medial half by the presence of conjoint tendon. What is the other name of conjoint tendon? Fox inguinalis. This conjoint tendon is contributed by upper neurosis of both transverse abdominalis and the internal oblique, strengthening the posterior wall on the medial half. And remember, while talking about the extensions of the inguinal ligament, we saw that some of the fibers from the pubic tubercle, they turn upwards medially, go in front of the conjoint tendon to insert into linea alba, the reflected part of inguinal ligament. It strengthens the posterior wall of the inguinal canal in the medial 1/4. Coming to the roof of the inguinal canal, yes, while doing the muscles, we learned that the inguinal fibers of internal oblique muscle and transverse abdominis, they turn upwards, backwards, medially, arching, forming the roof of the inguinal canal. And just now I told you what is the partial content of the inguinal canal? The ilioinguinal nerve. Right? How does it enter the inguinal canal? By piercing the roof. We know that the neurovascular plane in the anterior abdominal wall, it lies between the internal oblique and transverse abdominalis. So the internal oblique and the transverse abdominalis, they form the roof, isn't it? So the ilioinguinal nerve, the ventral rami of L1, which lies between these two muscles, it pierces the roof of the inguinal canal to enter it. Okay? And floor, yes, you can tell me, the floor of the inguinal canal is formed by the inguinal ligament, the grooved upper surface of the inguinal ligament, and in the medial part by the lacunar ligament. Coming to the inlet and the outlet. Why do we call it as inlet? Because the spermatic cord in male and the round ligament in female, they enter the inguinal canal through the deep inguinal ring. Okay, through the deep inguinal ring. And this deep inguinal ring, yes, you can tell me, it is an opening in the fascia transversalis. Where is it situated? 1.25 centimeter above the mid-inguinal point. What is mid-inguinal point? So here you see the anterosuperior iliac spine and this is the pubic symphysis, right? A point midway between the two, it is the mid-inguinal point. 1.25 centimeter above the mid-inguinal point, we see the deep inguinal ring and opening in the fascia transversalis. Just medial to it, we'll get to see the inferior epigastric vessels. Okay, and the outlet is formed by the superficial inguinal ring. So as you see here, the spermatic cord or the round ligament in the female as well as the ilioinguinal nerve that you see here, yes, it exits the inguinal canal through the superficial inguinal ring. And you can tell me the superficial inguinal ring is a defect in the external oblique upper neurosis just above and lateral to the pubic tubercle. Fine? Yes. So when this is asked as an essay question, for completion's sake, definitely you have to fill up the pages. You have to write about the defense mechanism for inguinal canal. So the inguinal canal with the deep inguinal ring, superficial inguinal ring and the Hesselbach triangle in the posterior wall, it forms a weak area in the anterior abdominal wall through which the contents of the abdominal cavity can herniate out, producing an inguinal hernia, isn't it? Okay, so what are the factors? And not all of us get this inguinal hernia, right? So we are all well protected. So what are the protective mechanisms by our body to prevent inguinal hernia? The inguinal canal itself is oblique, right? The deep inguinal ring and the superficial inguinal ring they are not in a but in different plane. Fine. And then, yes, when the intra-abdominal pressure increases, what can happen? The roof can come in contact with the floor. That will occlude the inguinal canal and the contents cannot herniate out. This is called as the shutter valve mechanism. At the same time, the posterior wall can push forwards and come in contact with the anterior wall. This is called as the flap valve mechanism. Remember the cremaster muscle, which lies between the external and internal spermatic fascia. It is an extension of the internal oblique muscle, right? So this cremaster muscle, yes, it surrounds the spermatic cord. It is innervated by the genital branch of genitofemoral nerve. The contraction of this cremaster muscle will pull the testis to occlude the superficial inguinal ring. This is called as ball valve mechanism. And so the superficial inguinal ring and deep inguinal ring are defect in the upper neurosis or in the layer of the anterior abdominal wall, right? So in where the superficial inguinal ring is present, the posterior wall of the inguinal canal in that area is strengthened by the presence of conjoint tendon and the reflected part of the inguinal ligament. At the same time, where the deep inguinal ring is present, the anterior wall is strengthened by the fleshy origin of internal oblique fibers. So all these factors, they prevent the development of inguinal hernia in most of us. Okay. So what you see here in the beginning of the session, right, we saw a case scenario, Padmama presenting with globular swelling in the groin, dragging pain. It was expansile and it was reducible, all that. So pointing towards inguinal hernia, right? Now, how to differentiate it from femoral hernia that we learned in lower limb? So what you see here is the femoral hernia. Remember, the abdominal contents, yes, will pass through the femoral ring, femoral canal, saphenous opening and then ascends up. That is the femoral hernia. So this is the inguinal ligament, right? Yeah. So as you see here, the femoral hernia, it lies below the inguinal ligament, below the pubic tubercle. Okay. Whereas the inguinal hernia, Yes, it lies above the inguinal ligament. So what are the conditions in which a hernia can occur in the groin? Whatever like increases the intra-abdominal pressure. In Padmamma, she was a pulmonary tuberculosis patient on medication. So she would have had cough, right? Yes, a chronic cough can increase the intra-abdominal pressure. Constipation, any tumor within the abdominal cavity, like, and yeah, certain other like multiple pregnancies. Yes, the abdominal wall becoming lax, and any surgeries over the anterior abdominal wall would have weakened the anterior abdominal wall. All these predispose to the development of inguinal hernia. Now, yes, we have to know about two terminologies: indirect inguinal hernia and direct inguinal hernia. So this term I used, right? Direct inguinal hernia. When the intestinal contents enter the inguinal canal through the Hesselbach's triangle, which is related to the posterior wall of the inguinal canal, it is called as direct inguinal hernia. Okay. Whereas indirect inguinal hernia, the entry of the intestinal contents into the inguinal canal is through the deep inguinal ring, an opening in the fascia transversalis 1.25 cm above the mid-inguinal point, through which the spermatic cord and the round ligament of uterus enters the inguinal canal. Okay. So, this indirect inguinal hernia can extend all the way into the scrotum, whereas the direct inguinal hernia will not completely extend into the scrotum, right? And yeah, because the process is vaginalis. If it is patent, it can reach all the way up to the scrotum in case of indirect inguinal hernia. What is the relation between deep inguinal ring and the inferior epigastric vessels? The inferior epigastric vessel is medial. The deep inguinal ring is lateral to it. And a Hesselbach's triangle, yes, it lies medial to the inferior epigastric vessels. So, when the hernia is going to come through the deep inguinal ring, the neck of the hernial sac will lie lateral to the inferior epigastric vessels. Okay. If the hernial sac, it reaches the inguinal canal through the Hesselbach's triangle, then the neck of the hernial sac will lie medial to the inferior epigastric vessels. Am I right? The direction of the inguinal canal, we saw it is downward, forwards and medially, isn't it? So when the intestinal contents enter the inguinal canal, then the direction of the hernia is also going to be downwards, forwards and medially. Fine. Whereas in case of the direct inguinal hernia, when the intestinal contents are going to enter through the Hesselbach's triangle from the posterior wall of the inguinal canal into the inguinal canal, it's going to be straight forwards. The direct inguinal hernia, it occurs in elderly, yes, and it is going to be bilateral because it's going to be a condition like as we saw, right? Anything that increases the intra-abdominal pressure. And whereas the indirect inguinal hernia, most of the times due to a patent process vaginalis, it is common in the young and it presents unilaterally. So that was all about inguinal canal. Now moving on to the last topic in this session, it's about the rectus sheath. Yes, so you can see here, this is the midline, the linea alba, isn't it? What is linea alba? Where the upper neurosis formed by the three flat muscles, they decussate in the midline that extends all the way from the xiphoid process above to the pubic symphysis below. Either side of the linea alba, the muscle that we get to see here is the rectus abdominis muscle. And this rectus abdominis muscle is well protected with the upper neurotic covering, both in front and behind. which we are going to call it as the rectus sheath. And yes, typically, what is the six-pack appearance that you see here is because of the tendinous intersections which are present in the anterior surface of the rectus abdominis muscle, connecting it to the anterior wall of rectus sheath. The presence of these tendinous intersections, it divides the rectus abdominis muscle into smaller segments to increase the power of that muscle. Okay? And the lateral border of the rectus sheath that you see here, that is given another name. It's called the linea semilunaris. And this is the linea alba in the midline. Okay. So now let us look into the formation of rectus sheath. So the rectus sheath, yes, it is an upper neurotic envelope, right, that encloses the rectus abdominis muscle mainly, but there are certain other contents also. Okay. And yes, what is the purpose of it? We have seen about flexor retinaculum and extensor retinaculum in hand and like in the upper limb, lower limb, right? So what was their purpose? They were like holding the tendons in position and prevent them from bowstringing, popping out, right? So similarly, this rectus sheath, it serves as a retinaculum, right? And yes, it prevents bowstringing of the rectus abdominis muscle. As I told you, it has a medial margin which we are going to call it as linea alba. And the lateral margin, we are going to call it as linea semilunaris. And I told about the tendinous intersections connecting the anterior wall to the anterior surface of the muscle, giving that six-pack appearance. So this has the anterior wall and the posterior wall. Now we are going to learn about the anterior wall and the posterior wall, their composition at different levels. So what you see here again is the anterior wall. This is the costal margin, right? Okay. So we are going to learn it in three segments. Above the costal margin, and then this is the umbilicus, this is pubic symphysis. A point midway between the umbilicus and pubic symphysis, and then the area below that. Okay, so 1, 2, and 3. So above the costal margin, the anterior wall of the rectus sheath is going to be contributed by only the upper neurosis of external oblique muscle. It is just the upper neurosis of external oblique. Right. Now, in the area below the costal margin and up to a point midway between the umbilicus and the pubic symphysis, this mid-segment area, the anterior wall of the rectus sheath is going to be contributed by upper neurosis of external oblique muscle. And yes, you can tell me the upper neurosis of internal oblique, it's anterior lamella. Okay, so please remember, it's both the external oblique upper neurosis and the anterior lamella of internal oblique upper neurosis. The lower part, this area, right, the anterior wall is the thickest because it is going to be contributed by upper neurosis of all the three flat muscles: external oblique, internal oblique, and the transverse abdominalis muscle. Okay, the posterior wall, let's now do it. So the posterior wall of the rectus sheath, you can appreciate the rectus abdominis muscle here, right? Okay, here also you get to see it. This again exposing the posterior wall, So again here also we're going to learn it in three segments. First is above the costal margin, and then a point midway between the umbilicus and the pubic symphysis, and then the area below it. So 1, 2, and 3. Okay. So in that first segment, upper segment, the posterior wall of the rectus sheath, this rectus abdominis muscle that you see here, it directly rests over the costal cartilages. The rectus abdominis muscle will insert into the xiphoid process, 5th, 6th and 7th costal cartilages. So that is what we are telling as the posterior wall of the rectus sheath. Its insertion above the costal margin, right? Now coming to this mid segment, that is from the costal margin to a point midway between the umbilicus and pubic symphysis. This mid segment, the posterior wall of the rectus sheath is going to be formed by internal oblique aponeurosis, its posterior lamella. Fine. And behind that, we'll get to see the aponeurosis of transverse abdominis muscle. Okay. And there is one important point here. I'll just erase few things so that it's very clearly visible. In the posterior wall, right? Yeah. So we have seen the upper segment, mid segment. We'll just finish the lower segment also. This part that you see here, the posterior wall is deficient because the aponeurosis of all the 3 flat muscles in the lower segment, they go for contribution to the anterior wall, isn't it? So here it's just going to be the fascia transversalis. Remember, we saw that the lower part of the fascia transversalis that extends from the anterosuperior iliac spine to the pubic symphysis is thickened to form the iliopubic tract or the Thompson's ligament. Yes, so that is what we see here. So this point where the posterior wall of the rectus sheath ends, can you make out a curved line? This is called as the arcuate line. This is one important landmark. It represents the lower limit of the posterior wall of rectus sheath. And yes, you can identify the entry of the inferior epigastric vessels into the rectus sheath opposite this arcuate line. Okay. So that was about the anterior wall and posterior wall. Now let us see about the margins, the medial and the lateral margins. The medial margin that you see here in the midline, extending all the way from the xiphoid process above to the pubic symphysis below. Yes, we call it as the linea alba. Why it is called linea alba? Because it is just formed by the decussation of the aponeurosis of all the 3 flat muscles in the midline, and it is entirely avascular. There's not going to be any blood vessel that you see here in the midline. So the incision here, it's going to be safe, but the healing is going to be difficult, okay, because there are no blood vessels. It's completely avascular, right? And this linea alba, from its lower end, it gives out 2 extensions. Some of the superficial fibers from the linea alba, you can see it entering the dorsal surface of the penis. It's called the suspensory ligament of penis. And from its deep surface, some of the fibers, they go behind the rectus abdominis muscle and insert into the pubis. Those fibers which are posterior, it's called as adminiculum linea alba. Okay. Coming to the lateral margin of the rectus abdominis, it is curved. It extends all the way from the pubic tubercle below to the tip of the 9th costal cartilage. And this is called as linea semilunaris, a very important landmark. And please remember, yes, we saw a picture, right, while talking about the anterior abdominal wall. The nerves that enter the rectus sheath, okay, they have to cross the linea semilunaris and enter into the rectus sheath. Okay, it crosses the lateral margin and then enters into the rectus sheath. So, an incision here, or when you're retracting the muscle, rectus abdominis muscle, we have to retract it laterally to preserve these nerves. The contents of the rectus sheath, yes, you can identify two muscles there, the rectus abdominis and one small muscle in the lower part, yes, we'll be seeing it, the pyramidalis. And the vessels that you get to see here, this one coming from above, right, entering the rectus sheath is the superior epigastric artery and the accompanying vein. Can you tell me what is it a branch of? Yes, we did it in thorax. The internal thoracic artery at the level of the sixth intercostal space, it will terminate into musculophrenic artery and superior epigastric artery. This internal thoracic artery will give rise to anterior intercostal arteries, two in each space in the upper six intercostal spaces. The musculophrenic artery will give rise to anterior intercostal artery in the 7th, 8th and 9th space. Whereas the superior epigastric artery, through the gap between the diaphragmatic origin from the xiphoid process and the 7th costal cartilage, through that gap, the foramen of Larry, it will enter the rectus sheath. You can see it coming down, right? And opposite the umbilicus, it will anastomose with the inferior epigastric vessels. Which are the inferior epigastric artery is a branch from the external iliac artery. The other branch from external iliac artery is the deep circumflex iliac artery. Okay, and then the ventral rami of T7 to T11 and the subcostal nerve, that is a T12, right? So all these are seen within the rectus sheath. You will not have a problem in identifying the rectus sheath. And can you appreciate the tendinous intersections here? Yes, they connect the anterior surface of the muscle to the anterior wall of the rectus sheath. They are three in number, one at the level of the xiphoid process, one at the level of umbilicus and the other midway between the two. This rectus abdominis muscle, it has its origin below and insertion up. So below, it has a medial head coming from the pubic symphysis and the lateral head coming from the pubic crest and tubercle. The fibers go up for insertion into the xiphoid process and the 5th, 6th, 7th costal cartilage. Okay. The pyramidalis muscle, please appreciate it's here. The small tiny muscle that you see here is the pyramidalis. This pyramidalis muscle, again, it originates from the pubic symphysis, the pubic crest, and it inserts into the linea alba. It is innervated by the subcostal nerve. It is considered to be a tensor of linea alba, the small muscle within the rectus sheath. Okay, so now moving on to the clinical relevance of the rectus sheath. So this is image A and B. What difference you appreciate in image B? Can you see the widening of that space between the rectus abdominis muscle on both the sides and the linea alba here? Yes, it is thinned out weaker. This is called as divarication of recti. It occurs, yes, as a very commonly seen in elderly multiparous women due to weakening of the muscles there. Okay. So here it is close and you can see the rectus abdominis muscle of both the sides far apart. And surgical incisions related to the anterior abdominal wall are many, but in relation to rectus sheath, please remember it can be a paramedian incision or a pararectal incision. The paramedian incision is few centimeter away from the midline, median plane. So here we make an incision over the skin, the superficial fascia, anterior wall of the rectus sheath, and then we cut across the tendinous intersection. And yes, we try to retract the rectus abdominis muscle laterally to preserve its nerve supply. Okay, because the nerves are entering it from the lateral aspect. The pararectal incision, it is placed on the lateral aspect of the rectus sheath, just inner to the linea semilunaris. Okay, care should be taken while retracting the rectus abdominis. It should be retracted laterally to preserve the nerves. If it is retracted medially, then the nerves can be damaged. Now, yes, let us work out few MCQs. All the following are modifications of external oblique aponeurosis except. So the superficial inguinal ring, the external spermatic fascia, the floor of the inguinal canal contributed by inguinal ligament and lacunar ligament. Of course, they are modifications of external oblique aponeurosis. The conjoint tendon is contributed by transverse abdominalis muscle and internal oblique muscle. A 42-year-old man was working out in a gym when he pulled a muscle in his abdomen. He developed severe pain and swelling and presented to the emergency department. CT shows that the right rectus abdominis muscle is markedly enlarged compared to the normal left and is also of much higher attenuation. He was diagnosed with rectus sheath hematoma. Identify the correct statement related to rectus sheath. So what are the blood vessels within the rectus sheath? The superior epigastric vessels, the inferior epigastric vessels. So as we see here, straining of the muscle, these vessels would have been stretched and ruptured, leading to rectus sheath hematoma. They have asked us to identify the correct statement. The anterior wall of the rectus sheath is thickest in the lower segment, not in the upper part. The lower margin of the anterior wall, it forms arcuate line? No. Where is the arcuate line present? It is the lower limit of the posterior wall of the rectus sheath, isn't it? The lateral margin is formed by the linea semilunaris is a correct statement. Pyramidalis is supplied by subcostal nerve. The deep inguinal ring is an opening present in the fascia transversalis. 1.25 centimeter above the midinguinal point and just lateral to the inferior epigastric vessels. From the margins of the deep inguinal ring, we get the internal spermatic fascia. Let's match it. The transtubercular plane, which connects the tubercle of the iliac crest on both the sides, it corresponds to L5. The transpyloric plane, L1. Subcostal plane, lower part of the costal margin, right, L3. Supracristal plane is the line that connects the highest point of the iliac crest on both sides. It corresponds to L4. Now, yes, this is a very high-yield topic which you should definitely memorize, right? This table. The xiphisternal, it corresponds to T9 vertebral level. And the transpyloric plane, yes, it lies midway between the xiphoid process and the pubic symphysis, right? So this transpyloric plane, it passes through the first lumbar vertebra, L1. The subcostal plane is the plane passing through the lowermost part of the costal margin. It corresponds to L3. Supracristal, that term might be a bit confusing. It's easy. It's nothing but supracristal is the plane that passes through the highest point of the iliac crest. It corresponds to L4. The transtubercular plane is the plane that passes through the tubercle of the iliac crest on both the sides, correspond to L5 vertebra. The interspinous plane, connecting the anterosuperior iliac spine of both the sides. Okay, that passes through the lumbosacral disc or the sacral promontory. And the plane of the pubic crest, it passes through the lower end of sacrum. Now, a few important points in addition. L3, it corresponds to the origin of inferior mesenteric artery from the anterior surface of abdominal aorta. L4, termination of the abdominal aorta into its right and left common iliac branches. L5 corresponds to the formation of inferior vena cava by the union of right and left common iliac veins. Okay, and there are a lot more events taking place at L1. Yes, L1, it corresponds to the termination of spinal cord. Right? It also corresponds to the hilum of both kidneys. Right? And again, the fundus of gallbladder It lies opposite L1. The neck of the pancreas, it lies at L1. Anteriorly, it is related to the pylorus of the stomach and posteriorly to the portal vein formation. Okay. Origin of superior mesenteric artery from the abdominal aorta, that also corresponds to L1 vertebra. Structure that underlies the pointer. The one that is pointed out is the median umbilical fold. Underneath it, we have the median umbilical ligament, which is nothing but the remnant of the urachus. Nerve supply to the cremaster muscle is from genital branch of genitofemoral nerve. So these three muscles are very important while we learn anterior abdominal wall. Come on. The cremaster muscle, we have seen it surrounding the spermatic cord. Okay, the fasciculi arranged around the spermatic cord. The dartos muscle is present, yes, beneath the skin of the scrotum, subcutaneous. The pyramidalis within the rectus sheath. Just now we learned, right? This cremaster muscle, yes, it is a continuation of internal oblique. Pyramidalis is also a striated muscle, whereas the dartos is a smooth muscle, right? Nerve supply of cremaster is coming from genital branch of genitofemoral nerve. Pyramidalis, come on, it is innervated by the subcostal nerve. Actions of cremaster muscle. That ball valve mechanism, yes, contraction of the cremaster, what will happen? The testis moves upwards and occludes the superficial inguinal ring. Yeah, and the dartos is going to be innervated by the sympathetics. The contraction of the dartos muscle, it serves as a thermoregulation for the testis and the scrotum. The pyramidalis, we have learned that it is a tensor of linea alba. So what is shown here is cremasteric reflex. What is cremasteric reflex? In the newborn babies, okay, or in adults also, if we stroke the medial aspect of the thigh, we can see that the testis on that side, it moves up to occlude the superficial inguinal ring. The afferent component for it, the sensation from the upper part of the medial side of the thigh, the ilioinguinal nerve with the root value L1. Efferent, the nerve responsible for the movement of the cremaster muscle, genitofemoral nerve, okay, with the root value L1, L2. The spinal center is mainly L1, right, for cremasteric reflex. So in this session, in detail, we have learnt about anterior abdominal wall, right? So what are the layers of the anterior abdominal wall? Why is deep fascia absent in the anterior abdominal wall? And what are the two modifications of the superficial fascia? At a point below the umbilicus, the fatty layer is going to be called fascia camper and the deep membranous layer is called the fascia scarpa. We trace the fascia scarpa right into the ears surrounding the penis, the scrotum and the perineum, the polys fascia is fusing with the posterior aspect of the urogenital diaphragm. What happens when there's a rupture of the penile urethra? The extravasated urine will collect in the superficial perineal pouch around the scrotum, around the penis and also extend in the lower part of the anterior abdominal wall but not into the thigh because of the Holden's line, right? And then we moved on to each muscle, external oblique, internal oblique, transversus abdominalis, their modifications and inguinal ligament extensions, fascia transversalis, its contribution. Yeah. We also learnt about Hesselbach's triangle, the inguinal canal, the different walls of it, anterior wall, the posterior wall, the roof, the floor, the inlet, the outlet, defense mechanism, the difference between direct and indirect inguinal hernia. And then we moved on to rectus sheath. Yes, what is the purpose of the rectus sheath? What are the contents of the rectus sheath? Yes, can you tell me the contents of the rectus sheath? The two muscles that rectus abdominis and pyramidalis, the superior epigastric vessels and the inferior epigastric vessels, And then the ventral rami of T7, T8, T9, T10, T11 and T12, isn't it? And the relevant clinical anatomy also we discussed. Hope you have understood everything. Happy learning.